Hi everyone, hope you have a good autumn feast and now resting or seeing TV and things like that. So I had a dilemma in the sense that whether I should make this video in English or Malayalam. There has been some input saying that to make it in Malayalam. But at the same time, there are a few people who are watching this who may not understand Malayalam so much. So that's why I decided to make. But it's always a dilemma because for me to make a sing and speak in English, even though I consider English to be my first language, but it's an artificial consideration in the sense that the reach of my mother tongue is always Malayalam, but I always consider English as first language because I learned it a lot. I still learning my English, so that's why. Anyway, just don't want to go into the controversy. I just want to say that there is a difference between being bilingual and being diglossic. Bilingual, I am a prototypical bilingual person in the sense that I speak Malayalam, I speak English, and I understand Malayalam, I understand English very well, Malayalam very well. But a diglossic person speaks two languages, but he cannot interpret or he cannot translate from one language to other which he speaks. That's a diglossic person. But actually speaks like a native speaker. He speaks English, he speaks Malayalam, but that's a different, probably different center in the brain. It gives a diglossic. But many of us will reach that stage if we at this rate of spread of English. By the way, I just saw on CNN that India is the largest country in the world where English is the official language. And even Malayalam is being eroded. Many people say father, mother, uncle, and all these things for relatives, and for many other things which they have difficulty in saying in Malayalam. They always say use English. So English is also an option, and not because it's not a colonial. We are all post-colonials. We speak English because English, just like we used to learn Sanskrit before. Sanskrit was maybe Aryan or whatever. Some people say they were here, but it's not our language. That's certain. But it has permeated Malayalam because that's our mother tongue. In Malayalam itself is not a single language. It's a mixture of all these things. Mainly Sanskrit has gone into the formation of Malayalam, 50%. 50% is Tamil and other languages. So this one we shouldn't have any argument saying that English is foreign, that this thing. It's not foreign to me as far as I am concerned. I have been learning English right from the maybe I learned in the Malayalam medium, but then I have been reading Malayalam English books right from 6th standard, I think, 6th standard. And there is an argument now that small children shouldn't be exposed to English. I can't say it is true that if you expose somebody, they speak English, do science in English, come back at home and speak in Malayalam. If they love the parent, they will speak Malayalam. Okay, it's not a problem. So I think I spent 5-10 minutes on this thing, which is not really my subject, but it concerns me a lot. Of course, this video I'll be making in English, and if there are any recommendations for Malayalam, and see, I don't see many people also seeing it in. If I do Malayalam the same video, I don't see many people seeing Malayalam speaking seeing it. So the reach will be better probably if I the same logic holds good for the English medium education. What people say is that you learn technologies in English, so if you have a job opportunities abroad, then it will be easier for you. Same thing, you'll get a higher reach if I do this thing. So I spent about 5 minutes speaking on this. The rest 20-25 minutes I'll be spending on this one, musculoskeletal disorders in elderly. Today I'll be doing the metabolic bone disease. There are two parts to it. One is metabolic bone, the other part is arthritis and other things, musculoskeletal. Other is. So metabolic bone is I'll go into. It's a short topic, but difficult as far as many of us are concerned. In the sense that bone metabolism is still evolving. The knowledge of bone metabolism is still evolving. We all know that there are three cells: osteoblasts, osteoclasts, and osteocytes. Osteocyte is another name for mature osteoblast, which has gone and got trapped in the bone lamella. The lamella is there. Lamella means bone columns. Bone columns in compact bone is called lamella. Lamella. And there are two types of bone: compact 80%, and this one, what is the deciduous bone, the soft bone, and the hard bone. Hard bone is more. So when we say bone, hard bone, but the other bone is also important. The bone grows from there. So the metabolism means it is the how the bone is made by these cells. Then how the bone is in a dynamic state all the time, being made, being unmade, or being broken down, resolved, then be blown again. So it's something like growing all the time till the end of your life. But towards your senescence, towards the end of your life, the rate of formation will be less, and the rate of breakdown will be more. That's when you get the metabolic diseases. Suppose you get the osteoporosis. Osteoporosis means a porous bone. Osteo means asti, Sanskrit, asti, and by the senile also, Sanskrit, senile means old. So osteoporosis is the first one I am going to talk about. Osteoporosis, its epidemiology is worldwide, and the older the person, older the women, it's a female preponderant, because it is the bone porosity has a lot to do with estrogen deficiency. After menopause, the people get a lot of this thing. So, I don't have to describe the clinical picture. Everybody knows it. As our female population age, many of them develop bend in the spine. In clinical, we say it is called what is it? Gibbous or other thing? Not gibbous, I think. Anyway, it's called a stoop. In ordinary language, it's called a stoop. Everybody, because there has been a vertebral fracture, and the height of the vertebrae has gone down, and as a result, the spine is bent forwards. So that's why they're walking like that. Then everybody knows that old people, especially old ladies, fall and break their hip fracture, and fall and break their forearm fractures. So these are the three areas where fracture happens very often. So I said because this happens because the osteoblasts have become old and they are not making enough bone, and osteoclasts may be overactive in this stage, because the osteoblast has a control on osteoclasts. Osteoclasts are it has a different cell line. Osteoclasts actually come from immunocells like macrophages, that plasma cell, that group. Tissue macrophage, that group. So it's a multinucleate giant cell, whereas osteoblast comes from the fibroblast group. That is a basic thing, or connective tissue group. So osteoblasts make what's called this one osteoid. And then they also make the mineral, the core of the mineral. That's called a kind of droplet, where they got the thing, the mineral nucleus there. There's a kind of droplet. It's extruded by the osteoblast. This may not be, many of you may not be aware this is what's metabolism all about, bone metabolism. So osteoblasts are is the cell which makes the bone. It produces connective tissue, the osteoid, which is nothing but collagen, and it also produces the nucleus or the center for this thing, bone mineralization. Then around these vesicles, which is secreted by the osteoblast, which has got receptors for growth hormones as well as for vitamin D. And so it attracts vitamin D and growth hormones, and finally it becomes calcium appetite. Not appetite. Appetite means calcium phosphate. Not calcium appetite. Calcium appetite means calcium phosphate. So calcium phosphate and deposited inside the osteoid. The osteoid becomes calcified. Osteoid becomes a calcified. Like you have fracture, then your osteoid is deposited, then it gets calcified. Same process going on, same thing. Then where does the osteoclast come in? The osteoclast has to remodel all these things. Remodel. So they break the bone, osteoclast, and for that they take a message through a messenger molecule called RANK, R-A-N-K. This may be again something everybody has to know, basic. The bone metabolism. RANK. That is receptor activator for something called kappa B, nuclear kappa B. That is seen on the surface of the osteoclast, rank. There is another thing, it's not secreted by the osteoblast, it is seen on the surface of the osteoclast. But what osteoblast secretes is called a ligand, it's called a rankle, a ligand for the rank. So that is a message for rankle, is a message for the osteoclast to go into activity. So sometimes if it has to be fine tuned and regulated, if it goes into out of its this usual thing, what happens is more bone is destroyed. That's what's happening in osteoporosis. That's what's happening in even osteomalacia. Osteoporosis, osteomalacia, and the Paget's disease. Paget's disease also same thing. Here, what happens in Paget's disease is osteoblast and osteoclast both are overactive, and all these things have in the background genetic defect, but they are not like chromosomal defect. It's called a single nucleotide polymorphism defect, SNP defects. That is, one gene can produce many alleles, many phenotypes. That is the thing. That has to be more than 1%, then it becomes significant. That is the genetic part of it. But genetics is there. Even osteoporosis, not every lady will get a fracture, but it runs in family. So how is it diagnosed? You have to take an X-ray, because bone osteopenia or the X-ray, the loss of density, X-ray density is the hallmark of osteoporosis. But that's not equal to osteoporosis alone. The same thing, the osteolysis or osteopenia you will see in the X-ray. Even if you take it for Malaysia also. Malaysia, mal means bad disease of the bone. Osteomalacia also. So actually, finally, you have to take a bone biopsy to get an exact diagnosis. Whether it is osteoporosis or osteomalacia, or even this one, the Paget's. Paget, by the way, is a famous the British. To start with, I don't know what he was. Probably he was a surgeon, but he became one of the main architects of what's called a surgical pathology. Paget. The same Paget who discovered Paget's disease in the breast. He has discovered malignant disease and all of this. So Paget's disease is nothing but osteoclastic activity plus osteoblastic activity. So the bone turnover is high. That's Page's disease. The difference is osteoporosis is pretty common. It's about 50% of the ladies after 75 may get it, up to 40-50%. But by 60 years, maybe 10%, 5% will get it. But if you got a predilection for it, you will get a fracture. So the X-ray, plain X-ray, you can just get the shadow, but you can actually get the thickness of the bone by what's called a dosimetry. That is dual, that's called DEXA scan, dual energy. That is the one you all see advertised. We are doing this study, DEXA. That is dual energy X-ray dosimetry. Dosimetry, I don't know why. It depends on the dose of the X-ray beam. I don't know. Dosimetry, I think, or probably the absorption of the X-ray beam. That's a dosimetry. So there you can get a score. It's called a T-score. T-score means actually your score or your X-ray absorption can be compared with the 30-year-old normal person, 30-year-old normal male or female. That's you get the T-score. The T-score is less than minus 2.5. That means it is less than 2.5 density of the 30-year-old person. Then you are supposed to have an osteoporotic bone. But it's not a clinically, it doesn't go parallel to clinical features, because those who have less than that, less than minus 2.5, say somebody having just minus 2, they can also get a fracture. So it is not a cut and dry thing. So when you prescribe this thing, it's not mandatory that everybody gets this thing to say that. Actually, there is another score called FRAX. FRAX. FRAX means your fracture risk at X. X means 10. You know, it's a Greek alphabet, X is 10. So fracture risk is 10 years. That you got all these inputs you take, like genetic, somebody in the family having had a fracture, or yourself had a fracture, or you are a smoker, alcoholic. Some ladies also use alcohol, not in our culture, many cultures they use it. So they are supposed to have a high risk for fracture. Those who smoke also, current smokers. Then those who have some disease, like they have bone, rheumatoid arthritis, or they have, say, multiple myeloma. But then it is not primary osteoporosis, it's secondary. Secondary osteoporosis causes are vitamin D malabsorption or deficiency of vitamin D because of drugs. Main drug is anti-epileptic drugs. Anti-epileptic drugs will induce the hepatic enzyme and produce the have a higher metabolism vitamin D, producing a deficiency. And corticosteroids action on this one osteoclast, and I think so, and move calcium out of bone. So produces osteoporosis. Corticosteroid and anti-epileptic drugs are the two drugs which are really cause for osteoporosis. So these are considered in FRAX. FRAX score is supposed to be better than getting a DEXA scan. Anytime better than getting a DEXA scan. So treatment wise, I've seen many of us giving calcium and vitamin D may not be needed in osteoporosis, because osteoporosis pathology is different. I told you, it's a genetic pathology with alteration in the osteoblast balance. But still, vitamin D can be given. I think vitamin D can be given. Calcium may not be needed. Many people think everybody is giving calcium. Why are you advising not giving calcium? You just find out for yourself why. Calcium may not be needed. Vitamin D you can give, because sometimes there is an overlapping syndrome, vitamin D deficiency. Going to treatment, what you treat is actually you treat the rankle, the signal molecule. There are you can develop an monoclonal antibody against that protein. It is called denosumab. But that is the last of the options in India because it's quite expensive. All these monoclonal antibodies are expensive. For us, we would have to treat them with what's called bisphosphonates. Bisphosphonates will protect the calcium in the bone. Bisphosphonate. Actually, it will protect the calcium from the site of the osteoclast. So it's an osteoclast swindling kind of drug. This thing, bisphosphonates. Bisphosphonate. I know two. One is called alendronate. I have not seen many, but this is the treatment for osteoporosis and as well as Page's disease. As about this one, osteomalacia, the treatment is vitamin D. The treatment for osteoporosis in our setup is bisphosphonates. One is the daily, it's the oral, one is the alendronate. But there is another drug which is called a solidronate or solidronic acid, 4 milligrams every year as an infusion. The only side effect can be a flu-like syndrome while you are giving the infusion. Then sometimes they can induce hypocalcemia because it somehow blocks the action of osteoclast, so calcium may not be transported out of the bone. So it can produce hypocalcemia. Sometimes you can unmask hyperparathyroidism. Sometimes if it is there, it can unmask that. Not hypoparathyroidism. So then you will have to give calcium and all those things. Otherwise, it's then of course long term. If you're giving for 3 years till you get a remission from osteoporosis, then there is a small chance of fracture because the bone turnover is not happening that much. So there is a risk for fracture. So senescent bone is accumulating. So there is a risk for fracture in the hip. And there is another thing called jaw necrosis. I'm talking about bisphosphonate. Bisphosphonate is a drug you have to give for the same osteoporosis, not calcium. Calcium we don't have to give because unless there is a intake is low. But vitamin D deficiency is quite common. Vitamin D you can give for osteomalacia because clinically it's very difficult to differentiate osteoporosis osteomalacia. So give bisphosphonate. Bisphosphonate. Again, I stress bisphosphonate. And the few rich people, you can denosumab, you can advise. It will be, I think, maybe 3,000-4,000 per dose. That's another drug. You can also try the parathormone, but the recombinant parathormone, genetically made parathormone. There is a small sequence of parathormone only, the first 30 sequence. Amino acid, it's about a 90 amino acid long or something. So 30 sequence, it's called teriparatide, T-E-R-I, paratide, T-I-D-D, teriparatide. Teriparatide is not as expensive as denosumab. Denosumab is the monoclonal antibody against rankle, RANKL. I told you about, the receptor activator of nuclear kappa B, which is the antigen or which is the signal molecule over the osteoclast. So it's an osteoclast stimulating thing, rankle, ligand. So you block that by giving denosumab, monoclonal antibody against it. At least remember monoclonal antibody, denosumab. So there are so many. Denosumab is the drug of choice. Then of course you have to, if the person is very frail, don't let him fall. You can make him fall proof by instituting something, how he falls, like that. That is there. And exercise therapy is important. The person graded exercise therapy to reduce falling. But most of the time for this one, spinal fracture happens without the person's knowledge itself. Or they'll come to know it, they just have some back pain. They come to know of it only after 4-6 weeks when they develop this kyphosis, not gibbous, kyphosis. Kyphosis is the medical term for the bend forwards. kyphosis, and then only you realize the person has a spinal fracture. So this is about osteoporosis. So osteomalacia, in passing, I have almost finished. But osteomalacia is like rickets. You can almost say it's adult rickets. Rickets is pediatric. That's why I'm not going into it. Rickets means it is the affection of the growth plate by the low this one vitamin D. Here, adult, it's not the growth plate, it's the whole skeleton affected, and it produces, the mineralization is not taking place adequately. So bone pain will be there. Bone pain is the main thing, and this Malaysia, bone pain, and then you can have fractures. In X-ray, you can get what is called this thing, some incomplete fracture. That's all. Name is that. You always see that in long bones and things like that. And what is that? Some name is that. I just forgot. Anyway, incomplete fractures can happen. So always give vitamin D to these people. Vitamin D either D2 or D3. By the way, D3 is not same as calcitriol. Calcitriol is the active form of vitamin D. That is a different thing. D3 is different. You can give D2 or D3. D2 is supposed to be vegetarian. D3 is supposed to be animal. So anybody can D2, almost not much difference. Either D2 or D3 can be given. Then coming on to the thing. So Malaysia can be eminently treated by vitamin D. And most of the time they develop it because they have some sort of vitamin D deficiency. Most of the time sun exposure is not taking place because all the time people through don't expose themselves. Put on a lot of coat and tie and hat and all those things. Then or otherwise also females especially they put on all these dress. So they are not exposed to sunlight. The another thing is drugs. I told you this anti-epileptic drugs introduce vitamin D for absorption. They had a malabsorption syndrome in the intestine because vitamin D problem. So that is for the thing osteomalacia. Hope everybody has followed osteoporosis, osteomalacia up to now. Same syndrome, same thing, a little different because osteoporosis involves the activity of osteoclast, the rankle is a signal, whereas the osteomalacia is basically a vitamin D deficiency. Then the only thing, the next one is the Paget, the Paget's disease. The other two are osteomalacia may not be as common as osteoporosis, but it still is there. But this one is it's supposed to be rare, but it's not that rare. It's the reported case in India is around 6 per 10,000. That is by now is a very rare condition. So you always have to suspect if somebody has. Another thing, Paget says there is a symptomatic, asymptomatic. Monostotic, one area bone only in the body, polyostotic. But a clinical diagnosis by the appearance of the person, the bone deformity. So generally they say bossing of the skull, deafness because the cranial nerve gets trapped in the boss because of a lot of bone activity, osteoblastic, then osteoclastic activity, both are there, and both bone vascularity goes up. I don't know if you can hear a bruise on the thing. I think you can in previous disease in some cases, but that is a full-blown clinical. You have to suspect all these cases. You have to do some basic biochemistry. Like in this case, alkaline phosphatase will be very high. Alkaline phosphate will be in the thousands. Will be Paget's disease. But this one osteomalacia, vitamin D level you have to check. Vitamin D level is very low means osteomalacia is the treatment. Diagnosis. Not osteoporosis. More than osteoporosis, more you will give weight to osteomalacia. So this one Paget's disease you have to suspect on alkaline phosphatase plus clinical also. Then treatment is the only one treatment you can have is in India. In our places mainly this bisphosphonate, mainly solidroid, because solidronic acid is supposed to be more effective than the daily thing, alendronate. Solidronic is given once a year. You have to give minimum 2 years to say that it's not working. If it's not working, you have to consider the monoclonal against rancor. That will keep the person in remission. It's not going to cure it because it's a genetic disease. It's a single gene polymorphic disease. SNP disease. So you can keep the person in remission. But always remember about jaw necrosis and hip fracture when you are giving long term. So what you can give, probably give a drug holiday after about 3-4 years of treatment, bisphosphonate therapy. So that is about this thing, Page's disease. Anything in Page's disease, this radiology will be helpful. You can do the CT or an MR, that will be helpful. Even X-ray will show disorganized bone in the skull and all those things. So, so diagnosis may not be that difficult if you do a serum alkaline phosphatase with a clinical suspicion. Always diagnose this thing. Not that rare, though rare, not that rare. That's a metabolic brain disease. Next time we will meet with discussing about this thing, rheumatoid arthritis, osteoarthritis, and polymyalgia rheumatica. That's only muscle condition there. Okay, thank you very much and good night.